My name is Patrick Carriel. I'm a former White House Presidential Innovation Fellow and also former ARPA-H. It gives me great pleasure to invite back to the stage Dr. Jay Bhattacharya, the director of NIH, and also Dr. Anthony Latai, the director of the National Cancer Institute. Follow a page out of Jay's professorial approach and do a little bit of a setup here. So this panel is about cancer and chronic conditions. Cancer is still the second leading cause of death in the United States, and there are over 60% of Americans who live with a chronic health condition. But having said that, because of the NIH and the NCI funding and research, cancer mortality rates have been reduced by 30%, and we heard that this morning, since the 1990s. And there are over 20 million cancer survivors who live amongst us. But yet, when we think about there's an ongoing, growing mistrust of the medical systems, because we're seeing that particularly among cancer patients, that there's a decline of conventional treatment in favor of alternative therapeutics. So this conversation is really around progress, priorities, and prevention. So with that framing in mind, I'd like to turn it to the both of you and start at a strategic level. I would love to understand, what are your strategic priorities as it pertains to cancer and also chronic conditions?
Tony, you should start.
Okay. With regard to cancer, I'd say that you hinted at sort of the mistrust. I will say, again, cancer does have a sort of live in a blessed state where polls will show, if you look at now, that like maintenance of trust in the sort of cancer research community has been maintained pretty well through the last few years, and there still is sort of an overwhelming trust of people who do cancer research and oncologists who give cancer care. That said, I do think that we would benefit from people having a better understanding of what the National Cancer Institute has done and how, when we see statistics like 70% 5-year survival with cancer, 30% reduction in mortality, as well as individual cancer, amazing improvements since over my career. A great example is the disease multiple myeloma, where when I was starting my training, median survival was 2 years or so. Now median survival is essentially not really known because people are living for something like a decade at least with the disease as a median. So there have been a lot of these individual victories, and if you watch TV, you'll see ads on TV for this drug from Lilly, that drug by Pfizer, something else by Novartis, that are often successful and very effective drugs that have changed people's lives in a lot of ways. What I think is missing is an appreciation is that for every single one of those drugs, it started with an NCI grant. And that's our responsibility to communicate that to people. And I think that will help trust and help people make good choices. And also, hopefully, we can communicate the methods that we use to get by prioritizing one drug over another. So we're going to start a communications campaign in cooperation with the NIH. I think Jay likes the idea too, where we're just going to start telling people, give an example of a great story, someone who's been cured of a disease, and then show like, that's a great outcome. How did that happen? And then we can pinpoint, started with this NCI grant, and then this NCI grant, and then this NCI grant. Because I can tell you, as I say, all these things started with NCI grants. So part of what we want to do in restoring trust and making better communications and making a better communication with the American public is to tell them what we've been doing. That yes, we have enjoyed a lot of taxpayer funding over the years, but it has also done a lot of good, and you are now realizing the benefits of all that.
Jay?
Yeah, Tony's exactly right. Like the investments that we've made in cancer over the decades. Let me just tell to put some flesh on the bones of it, to tell a little bit of a story of the conquest of Hodgkin's disease, Hodgkin's lymphoma, which is a kind of cancer. In 1950, if you had Hodgkin's lymphoma, it tended to infect, hit young people. Actually, it was a death sentence. Like there was basically no treatment that would work. over the course of decades, slow progress with ideas from the bench, but then also randomized trial after randomized trial after randomized trial, tweaking the sort of formula for how you manage it. Hodgkin's disease now is a curable disease. Hodgkin's lymphoma is a curable disease. And it's remarkable to think that science can achieve something like that. Something that was a dread condition now entirely fixed. And, well, I mean, you still have to go through the chemotherapy and all that, which is kind of bad. But after you get through that, you're going to survive. I want to add another part to that, which is the part that's at least as important, which is how do we prevent cancers in the first place? Right? What lifestyles can we undertake? What diet can we eat? Both of those work together to address cancer. And the NCI is absolutely devoted to doing both. Tony, you can talk about the initiative you just told me about.
Right, an initiative that the NCI helped organize along with some of the other institutes at the NIH. It does, I think, two excellent things. One, it puts a focus on prevention and screening. Phil Castle taught me this, and he works at the NCI, that the best cancer is the one you never get. And if we can prevent it with prevention and screening, that prevents a lot of morbidity, mortality, and expense. But we also recognize that there are parts of the country where not only access, but just the desire for screening is less. The uptake for screening is less. And these are geographically distributed sort of in a corridor where there are bad cancer outcomes east of the Mississippi, largely east of the Mississippi, but includes like Oklahoma, Alabama, West Virginia, Kentucky, and I think I might be leaving maybe Mississippi. But bottom line is these are communities that are not getting the screening that they need. And it's not just for cancer, it's for other metabolic diseases and heart diseases as well. So we want to put together a program. In fact, we put together a program that was sort of working up through the echelons, made it through the Bhattacharya echelon very recently, where we want to bring screening to these people, and we figure it'll be best performed if we can do it as a package where we do multiple screens at the same time. So the idea is to start it where it's needed most in these in this geographic distribution, but if successful, broaden it to cover the entire United States. And that's not going to happen overnight, but you have to start somewhere.
Sorry, go ahead.
No, I just was going to expand upon that. Would love to actually get your take on the interplay between chronic conditions and cancer. In fact, how much of our cancer burden today is really a result of chronic inflammation or immune dysregulation?
So that is a very tough question, which is why Jay politely paused and let me address it.
You're the NCI director.
So if you look at it more broadly, part of what you can consider is what proportions of cancer are sort of preventable, okay? I would say that it's worth acknowledging that certain aspects of cancer are bad luck, okay, and not preventable, okay? And I would say there's various different estimates of this. I'd say a working estimate would be something like maybe 40% of cancers would be preventable by either lifestyle interventions, screening, or whatever. So roughly half of cancers maybe are preventable. And we already know that there are certain inflammatory conditions that definitely contribute to cancer. These would include Crohn's disease, ulcerative colitis, hepatitis, I'm probably leaving out a ton of other ones that definitely is. So we know this happens. So we do have individual screening programs that are directed at some of these. Some of these are driven by infections. And in some cases, vaccines have been shown to reduce the risk of some of these diseases. Examples would be the hepatitis B vaccine and the human papillomavirus vaccines, which reduce the risk of liver cancer or cervical cancer and some other cancers in the case of HPV. So another way of addressing some of these inflammatory and infectious conditions is to prevent the infection itself before it reaches an inflammatory stage.
Let me add to that one, a geeky subpoint. You've heard of whole body scans, right? And there's this the science fiction idea, if anyone a Star Trek fan remembers the tricorder, we just do the tricorder. We get bones to like do a tricorder scan of you, and then they're going to be able to find the cancer and in its early stage and automatically get rid of it. The hard part about that, first you have to do science to like figure out what the early signs are, but also if you have an environment where there's sort of a low like the cancer is relatively rare, and you do a scan, no matter how almost no matter how accurate it is, a lot of the people that are positive are going to be false positives, because most of the people in the population are negative, and so you have to be very, very careful about these things, because you can cause people to feel tremendous anxiety over a deadly disease that people dread almost more than anything else, when in fact they don't have it. The genetic revolution, for instance, has led to the capacity potentially for us to be able to identify genetic risks of cancer for very, very large populations. But it's really noisy sometimes. Just because you have a genetic marker does not mean you're automatically going to get that cancer. And so then how do you change your life? What do you do? That's the hard question.
So one approach that we're interested in, this encompasses something you may remember, like the past couple decades, where we've been looking at like personalized cancer therapy, where perhaps you identify a mutation or some other feature of the cancer that says, this particular drug will work. Well, people are taking some of those concepts and moving it over to what we might call personalized prevention. That is to say, prevention and screening technologies that you don't apply to everyone, but rather you use some study to identify a high-risk group that you can selectively apply. Now, we already know how to do this in terms of certain lifestyles. For instance, smokers would benefit from lung CT screening. People with a family history of colon cancer would benefit from early colonoscopies. So we know some of this. Now we want to turn it to more molecular, into more molecular terms, where can we study things about people, their genes, something else about them, their metabolism? Can we study something else about them that will indicate, they're at high risk for cancer X, and therefore they're a good place to employ screening tool Y? Because there you have less of a risk of false positives if you identify a high-risk population. I think Jay will agree with that. And so we sometimes think to move towards a better screening and prevention strategies might be a two-tiered system, where the first tier is sort of identifying a high-risk population, and the second tier is actually doing the definitive screening study.
So both of you just talked about screening and identification. From a budget and investment standpoint, how are you driving a delicate balance between prevention versus treatment, individualized care versus like population health impacts?
I think one of the things about prevention is that, frankly, it's held to too high a standard. What we ask sometimes of prevention is that it saves money, right? That any prevention measure you take, any screening measure you take, has to save money, right? But if you think about it, that's not right. If the prevention costs some money, but then prevents a whole bunch of human misery, illness, disease, cancers, it's worth spending money to do that, even if it doesn't reduce our total healthcare burden. It'll improve our health and well-being. And maybe that improvement of health and well-being may be money better spent than money treating people who've had advanced cancers. And so I think this like tendency to like say, okay, in the economics of this, to like want to hold prevention to this, just a higher standard of what effects it's going to have is really actually kind of unfortunate. But that doesn't mean that every single thing you can do is the right thing to do. That's what Tony's talking about is so important, right? So you want the screening to be targeted, and the more advances we have in personalized medicine, where you can get better answers about you rather than population averages, the better we'll do with that. Yeah, and it may be worth it even if it does cost some money.
Right, and it often will cost money. Generally speaking, we found, at least so far in cancer, a life saved from prevention versus a life saved via a curative therapy. The life saved via prevention is sort of cheaper generally. I think, however, Jay points out that the difference between those may narrow as we're going for more and more cancers, but that doesn't mean it's the wrong thing to do.
And just on the treatment side, like something that we're seeing as a growing trend clearly is an interest towards like the off-patent, low-cost therapeutics in cancer, specifically ivermectin, menbendazole. I'm curious if NIH and NCI are going to establish some rigorous studies around it so we can understand like the legitimacy behind these claims.
So first, mebendazole is actually in clinical trials. I think so. It probably functions in an understandable way, probably operating on a part of the cell called the microtubules, and we have other drugs that work that way. So it has one of the things we like to see in moving a drug forward, which is something of a plausible biological hypothesis, and it's being studied. It probably, just to be clear, we should frame our expectations a little. This is not, if it has any effect at all, it's not going to be a standalone drug that people take and cure their cancer. That doesn't mean it's not a useful therapeutic. It's being studied in combination with other things to see if it makes them work better. And that's completely legitimate because it's a well-tolerated drug, and if it makes other things work better, why not? With regard to ivermectin, both of these are anti-helminth, sort of like anti-worm, anti-parasitic type drugs. This operates, it's used, it actually won a Nobel Prize for its effect as an anti-helminth, and it works on invertebrates. We're all vertebrates, we all have spines. It works on invertebrates by inhibiting a particular type of chloride channel that we don't have. So you get a great therapeutic index. You know that it's going to operate on the invertebrate, but it's not going to operate on us, and that's why it works. And that's why it's a good drug for that. I would say the biological mechanism for it operating in cancer is less clear. It actually has been studied, both with NIH funds and outside of NIH funds, both in the Petri dish, and it's actually been in clinical trials. If it has a signal, and if it has ivermectin, if it has a signal, if it has efficacy, just again to frame expectations, it's not, at least on a population level, it's not going to be a cure-all for cancer. However, there are enough reports of it, enough interest in it, that we actually did, ivermectin in particular, did engage in sort of a better preclinical study of its properties and its ability to kill cancer cells, and we'll probably have those results in a few months. So we are taking it seriously. But I actually want to frame that part of your question a little differently, or get to another aspect, and that is, how do we figure out what drugs go forward? That isn't easy, because there's a lot of drugs and things outside what we conventionally call drugs, and we don't have the resources at the NCI, and like the United States doesn't have the resources to bring everyone forward. It costs money, but it also costs patience, right? You need to really know if something works on a population level, you need to have a large number of patients, 100, maybe a couple hundred patients. And we can't be exposing these patients who need an effective therapy to futile therapies. So we have to prioritize what drugs we actually get to patients. And in order to do that, what we have found works pretty well is we want to have an identifiable mechanism of action, something plausible about why it would kill a cancer cell but not all the other cells in your body. Okay? We also want to see some preclinical data that it actually, if you put it on cells, it kills it. This is what I've done for my living for many years. And drugs that don't have the property of like killing cells in some way aren't going to be successful in the clinic. Then we have some other maybe more complex preclinical studies, including toxicity studies, to make sure that they indeed won't, even if they're killing cancer cells, if they kill your heart, that's no good. It won't be tolerable. Only then can we consider bringing them to clinical trials, and then it'll go into early phase clinical trials where we'll test it on people, and one of the priorities is to ensure that it's not toxic, maybe get an early signal of whether it actually has therapeutic advantage in a cancer. Now, some of these studies have actually been done in ivermectin, and I can tell you again, it's not a really strong signal. It's something we're continuing to study. It's a cheap drug, and it's tolerable, and in that respect, it's appealing. But I also want to say, this doesn't rule out, do hear individual reports of people having taken it and found that they had a response to their cancer. This doesn't invalidate their personal experience that really happened to them. The problem is, at the level of the NCI, we have to make decisions about whether going forward with the drug is going to, even if that person has a very legitimate experience of a response, that's not a question that we need to address. We need to address the next 100 people we treat, will they have a response? And that's why we need to do these clinical studies, which is, as I say, we are doing some of them. And if the answer turns out no, it doesn't invalidate that person's experience, but it doesn't really allow the NCI to recommend it as a drug that is likely to work for a broad population.
Can I follow up with that? Because it's striking, right? If you listen to Tony carefully, the openness that he has to new ideas, but then also applying the rigorous methods of science to those new ideas, right? I think a lot of the distrust, and frankly, some of the things I've seen be recommended for cancer that doesn't really have the backing. Nothing we've talked about so far. They happen because the people don't trust medicine anymore. I think there was a JAMA study a couple years ago that only 40% of patients trust their own doctors, something on that order. It's absolutely shocking that this level of disconnect between the healthcare system and patients has come about. Because traditionally, the set of people that people trusted the most was their own doctor. And so a lot of the impetus, I think, for this is this distrust. What you're hearing at the NIH now is an openness to ideas, even ideas that scientists would say, "Oh, that there's no way it could work," but nevertheless applying rigorous scientific methods to those ideas. You have to take ideas seriously, even ideas that we don't, I as a scientist would find but unlikely. But if lots of people believe it and it's moving public health, we as an NIH have an obligation, again, to treat it seriously. And sometimes you learn things that you would never expect to learn.
So anyone here in the audience ever hear of an author named Ring Lardner? He's an American author of sort of early 20th century. He was a sports writer, but also a humorist. And he wrote a book that involved a travel with a son with his father, a young boy with his father. And at some point, the son asks his father a sort of tricky, somewhat potentially embarrassing question. And the quote I always remember is, "Shut up, my father explained." And I want to say that too often is the response that people have gotten from the public health community when they have an experience that's different from the canon, that they have an experience or they have a question that's different, or they want to question some underlying assumptions. And rather than giving it a respectful hearing and framing an answer in words that a lay person can understand, too often that person is dismissed or met with derision. And that's no way to perform public health. In order to restore the trust, there has to be some mutual respect. I understand that the people that I'm going to be talking to a lot of the time aren't trained in oncology, just like I'm not trained in, say, refrigerator repair or flying an airplane, okay? They're going to know more about that than me. I wouldn't be expected to repair a refrigerator. So we have to communicate using words that people understand. And part of that communication is I think, explaining the methods we use to prioritize some drugs over others. I can assure you, at the NCI at least, we aren't motivated by preserving profit for big corporations, which you hear that said, or we are motivated by one thing, and that is to reduce the burden of cancer in America.
Firstly, it's fantastic to hear that we're running these tests and running these trials. And so, yes, absolutely, let's do them. Because often the pre-trial economics is a rate-limiting factor in deciding what drugs are going to be tested or not. So, and that's a gap that the big pharma will leave behind. And it's great to see like the NCI will step up and address some of those.
Yeah, you just spoke about early phase clinical investigation. Another thing we need to do that I'm going to start getting more involved in. So I keep talking about things I'm starting. I want you all to realize I started September 29th. The government immediately shut down for 7 weeks. Then there was Thanksgiving, then there was Christmas, then we're faced with others. So I'm talking about starting a lot of things because it just hasn't been possible.
Tony's, if you like actual days in work, it's I think it's like a month and a half. I think you've been in, I mean, it's amazing how much he's accomplished in 6 weeks. Just wait for 6 years.
But one of the things we recognize is that all clinical trials, including early phase, I'm going to focus briefly on early phase clinical trials. That's when we don't really know as much about the safety or the efficacy of the drugs. are too slow. It's too slow to get from concept to a finished trial in the United States. And there's a lot of different bodies involved in how this, why this is. Okay, there's the NCI, the FDA, the individual cancer centers, and other groups as well that are involved. And what's important is everyone recognizes it's too slow, but what's important is to recognize where the blocks are and how to make it better. And I've mentioned this before, what I find is if you're talking to one person, it's always the people not in the room that are to blame. And even though everyone is well-intentioned. So part of what we want to do is bring everyone together. And this, I explained to Jay, and I talked to the secretary about this, and he's very anxious to move this along, not only for the sake of just improving our access to better medicines in America, but it also becomes a biotechnology competitiveness issue, where our early phase clinical trials are going overseas, some going to China, but believe it or not, a lot of them going to Australia. Okay, Australia, which is not a totalitarian state experimenting on political prisoners, they just figured out ways to do things faster and more efficiently. So we needed to learn about how they're doing things, for instance, and bring it back here so we can once again do our own early phase clinical trials here in the United States.
Thank you. I have another controversial question. There's a growing concern among patients about COVID vaccines and possibly resultant cancer presentations. And I'm curious to get both of your take on that. How does NIH respond to it? What can NIH and NCI do to really possibly run studies to validate or discredit those claims?
I can start. So one thing I say, the data to date is lacking. I think we can rule out a big signal with regard to, say, COVID vaccination inducing tumors. Of course, there are literature as well as individual patient experiences. I got the shot and then my tumor was recognized. And I'll get back to that in a second. But so far, the epidemiologic data doesn't support a big risk. I think we can't eliminate a small risk yet. Further studies need to be done, and indeed, we're studying that at the NCI, and probably others are studying it in addition. But I also want to point out two potential explanations for the experience. One of the experiences that is sometimes reported is like, I got a COVID vaccine, and then a week later, my cancer was diagnosed, so, and a causal relationship is made. I'd say even in the reports of some of the reports of, oh, is there an increased risk, or some of these observations, they make it clear that they cannot establish a causal relationship. And I just want to point out hundreds of millions of people in the United States got COVID vaccines, and many people, a couple million people a year, are diagnosed with cancer. So there's always going to be some concordance between those two events. With regard to sort of the rapid inflammatory growth of a cancer or observation of a tumor, I would say this, that's inconsistent with almost any tumor that we know that would go from undetectable to detectable within just a couple weeks. I would guess in some of these cases there's a plausible alternative explanation, and that is that the COVID vaccine is acting as some sort of a broad immunostimulant, and that actually there's a tumor there that is suddenly swelling because of the body's immune response to it that was maybe a little bit latent, but a COVID reaction woke up. To support that, there actually is evidence that the co-administration, fortuitous, I don't think it was intentional, co-administration of COVID vaccines with certain immuno-oncology drugs approved by the FDA actually improved treatment. So I suspect in some of these cases what we're seeing is an inflammatory reaction that is provoked by the COVID vaccine that makes a cancer that was already there more detectable because you get a swelling. I don't know that, that's just a hypothesis.
I'll tell you, like I was a critic of the use of the COVID vaccine, especially in young people, because I thought that the risk-benefit profile didn't make sense, and there was early signals of heart swelling, myocarditis, especially in young men, that I found very concerning, and I've also been looking at this evidence, more from an epidemiological point of view than a cancer biology point of view, for a link between COVID vaccine administration and cancer risk, and I'm not seeing it. Again, as Tony says, that doesn't mean that it's invalidating the experience of people who have cancer, that have had cancer in close conjunction with getting COVID vaccine. the causal relationships like this are very difficult to find. And to me, the way that I'm thinking about approaching this is, I want to take those ideas seriously and address them with rigorous science. I don't want to just dismiss them because I personally don't think I'm seeing this link. And so, we're asking questions that, I think that it traditionally the old NIH wouldn't ask. The goal is to apply rigorous science to answer those questions in a respectful way. And that's.
I also want to say is that what I'm saying, I'm giving you what I understand about the science. And I don't want you to make a bridge to a specific policy indication. I would say that if you're using as a policy indication, this vaccine does not cause cancer, that's the lowest bar ever for a policy indication. That is definitely not good enough to recommend any therapeutic or preventative that it doesn't cause cancer. So I'm not making a policy recommendation. I'm just saying, as far as I understand, there isn't a great linkage between administration of the vaccine and getting cancer.
Thank you for that answer. I want to switch gears and talk about pediatric cancer. This was called out in the MAHA strategy report that came out in September. How are we thinking about it? It's still the #1 cause of death in children in America. What can families expect in terms of both research from a prevention and treatment perspective?
So, pediatric cancer is and has been for a long time a high priority at the NCI. The support that we give for pediatric cancer research exceeds its sort of epidemiologic frequency, because I think we recognize that there is a special horror and a special burden of a child getting cancer that goes beyond what there is for an adult getting cancer. And so we support very basic research, very basic molecular research that contributes to the conquest of pediatric tumors. We fund clinical trials for pediatric tumors. We also do cell biology research that affects pediatric tumors. Sometimes we can directly classify these as pediatric studies. Sometimes it's just more general basic biology that can then be applied to pediatric studies. But I can assure you, we spend many hundreds of millions of dollars a year studying pediatric cancer. And these have yielded benefits. I think one of the most obvious benefits over the years is you can look at pediatric acute lymphoblastic leukemia, kids' leukemia. The cure rate for that now in the United States is about 90%. And this was due to a lot of excellent biology as well as painstaking clinical trials over the last, I'd say, 30 years, where we went from a single agent at Sidney Farber at the Dana-Farber Cancer Institute to today's regimens, which now, by the time you're done treatment, probably you've seen 9 or 10 different drugs. And you can't assemble something like that overnight. But patient, careful, scientific empiricism essentially conquered the disease of pediatric ALL.
I spent the most depressing month of my life at the Dana-Farber Cancer Institute as a medical student. I was a medical student in the pediatric cancer ward, and they treat not just ALL but a whole host of other pediatric cancers that we don't have great answers for. Right. And then so the conversations with parents and is just excruciatingly painful.
Yeah, but we have definitely not stopped. Yeah, we're not declaring victory. I think this administration is firmly behind it too. I think you can recognize that. If you look at right before the shutdown, September 30th, the final executive order was an executive order for an earmark of $50 million toward the Childhood Cancer Data Initiative to apply artificial intelligence to that at the NCI, which we have done. But I think that shows that this is high in the mind at the highest levels of the administration and in the NCI to continue research in pediatric cancer.
Absolutely. And let me give you another concrete step we've taken. So we have at the NIH a clinical center. It's America's research hospital. And it's a fantastic place. But what we don't have the capacity to do is see really, really sick kids. And so I've ordered the establishment of a pediatric intensive care unit. And now we were seeing some sick kids, but now we've doubled down on our investment on that. The reason why that's important is that means that that we can initiate research projects just in the bench to bedside way, to bench to bedside, bedside to bench to bedside way that Matt was talking about earlier, at the NIH directly. With this investment in this pediatric intensive care unit, because now we can really manage sick kids there. In order to get answers for kids with pediatric cancers that aren't like ALL, where we have such great answers now, we have to have that capacity. And even in ALL, it's still very important. Like one of the big things about ALL is that I think this was true certainly when I was a med student. I think it's a little less true now. But like the treatments would lead, you'd cure the cancer, and then 20, 30 years later, the kids who had been cured of cancer would show up with heart failure from the chemotherapy. And there's been a lot of work to like address that.
Right. So there's curing the cancer, and then there's also improving the survivorship, the experience of survivorship after that, so people can emerge from these treatments with normal intellect, normal longevity, normal hearts. We feel that's very important. Another nice feature of the NIH is there's, so if you bring a sick child there and they might have a long therapy, you might want a place to stay. And there's this beautiful thing called the Children's Inn at the NIH that is nonprofit organization, nice building. I got to visit it a few weeks back with Admiral Christine. And I'm telling you, to me, it was very heartwarming to see what capacity there is to handle not just the specific high-tech medical treatment of the patient, but also a place for the little kid and their parents to live while all this is taking place in the hospital right across the road.
Fantastic. I want to go back to like something that was mentioned in the earlier panel about taking more intellectual risk. I'm curious if you can comment as to what would that look like in the field of cancer that patients and clinicians can start to see as like tangible outcomes of that taking more intellectual risk posture?
Well, part of the issue of risk is some are going to fail. So we can't hold the standard that every one of those things has to score if it's high risk. But I'll give you an example of a high risk proposal that we're pursuing that you'll hear more of in the coming months, which is cancer vaccines. Okay? Now, cancer vaccines are very different from vaccines to prevent infection. When you're using vaccines to prevent infection, you're often vaccinating a population of healthy people. So you got to be really sure it's a super safe vaccine. In the case of cancer vaccines, you're talking about someone who likely has an expected survival of less than a year, okay? Very different population, so you're willing to do more innovative things and take greater risks, okay? There's a lot of cancers where the treatment starts with initial operation. Let's say pancreatic cancer, so the pancreatic tumor is removed. But we know there's a very high risk of recurrence. Most of the people recur, and most of the times they will die of their tumor. So how do we prevent that? Well, and that's known. I mentioned pancreatic cancer because that's known as a very tough tumor to treat. What's exciting is in the last few years, people have been doing studies, small studies, mind you, on different types of cancer vaccines. These are either peptide vaccines, little fragments of proteins, mRNA vaccines, or they're vaccines where whole cells are put in the patient. But there's some very exciting results that even in these really miserably hard cancers, we can reduce relapse. So one of the things I want to do with immuno-oncology therapies that I find very exciting is to accelerate first-in-human testing. There's a lot of ideas about how to make these things better. And it's hard to know but discriminate the good ones from the bad ones because the immune system is so complex. It's hard to do that outside of a patient. So we need to get to clinical trials faster. So I've started an initiative where we've empaneled a series of experts from around the country. How can we do this? I want to organize several layers of funding, both from the government as well as non-governmental sources, to give these people the resources they need to place a bet on a few of these strategies and see, can we really finally make an impact in some of these really tough diseases? So that's what I mean. So taking a risk is going to take resources, and we could spend this money and find out, and all we find out is, well, that didn't work. okay? And then we'll have to try something different. But that's part of what a high-risk initiative looks like.
Can I tell a pair of stories related to this? Because just the idea of using our immune system to attack cancer was a radical idea in the 1990s when I was a medical student. And it took a lot of intellectual courage to get to the point where you could even try them. Frankly, I think it just took too long. And now what you're seeing is the fruition of these ideas, which I'm really hopeful that they'll pay off with big advances in how we treat really intractable cancers. So that's a success story of a risk taken. Let me give you another story of a cancer approach called anti-angiogenesis. In the late 90s, so this is a drug that prevents your body from producing blood vessels. Cancers are fed by blood vessels. In fact, one of the things that solid cancers often do is send out signals to your body to produce blood vessels because they need to get fed, right? And so the idea was that anti-angiogenesis drugs would potentially solve all solid tumors. That was the promise I remember hearing in late in medical school.
Right. Jim Watson, it's going to cure all cancer.
Cure all cancer. It didn't work out. That was a risk that did not pay off. But that same strategy is now used to treat retinal bleeding and macular degeneration. Right? That strategy of anti-angiogenesis turns out to have an impact on fundamental eye diseases that cause blindness for countless people. With a strategy that ultimately didn't work at the scale one hoped for cancer.
Okay, I have one more question, and then we'll go to the audience and get their questions. Jay, you spoke about in your opening remarks about bringing upon the second scientific revolution and replication being at the core of it. I'm curious to get both of your pointed view on this as to, is there a landmark study within cancer and within chronic conditions that you would like to see replicated?
Okay, I'm gonna punt on that specific question, but I will say that there's a really interesting study about trying to replicate I think it was 100 landmark studies in cancer biology, where the conclusion from this replication effort, randomly chosen papers, was that most of them didn't even describe their methods in sufficient detail where a replication could actually happen. That's a major problem, right? So, so the replication revolution then gives you a chance to look and say, well, look, we shouldn't believe a result just because it's published. At the same time, the reason I'm punting on this is I don't want the government to pick and choose and identify studies to go after. I've seen this kind of power used essentially to go after disfavored people too much. I want the scientific community to engage with that and say, well, what are the ideas, sort of the rate-limiting step ideas, where if it turns out to be true, then the field will go one way. If it turns out to be false, the field will go another way. And focus our replication efforts on those things, not where the government's picking and choosing which scientific ideas to pick at, but rather to let the scientific community embrace this collaborative spirit of replication that ought to be the standard of truth in science.
Yeah, I think that's right. The one point I want to make is that with regard to replication, that crisis is generally not applied to most, I think, clinical trials, because it's hard to, unless there's absolute fraud, which is highly unusual, because it's hard if you enroll the right number of patients and you show a significant effect in those patients. That is something that is hard to sort of uproot and overturn. But the preclinical studies that drive those clinical trials, I think, is where we are interested. And I think Jay's right. You want to go after the highly leveraged ones, the ones where, hey, if that's true, man, we got to make a big investment in it. And if it's false, we should leave it alone. Those are the ones that you got to go after.
And on the clinical trials, sometimes you do see some reversals, right? You see clinical trial A finds something, and then clinical trial B finds the opposite, or finds a different result. Often those are learning experiences, because the idea that and the things that worked in situation A doesn't generalize to situation B, and then you try to figure out why that's the case. The replication crisis isn't to invalidate a whole bunch of ideas, but rather to stimulate a conversation among scientists about why things work when they do work, what are the conditions, just to do more rigorous science.
Excellent. Thank you very much. All right, here's some audience questions. Like some of these questions we've covered already, but I think it'll be good to just touch upon them in case there's more to add. Here's one question. The gold standard for cancer treatment is surgery, radiation, chemo, and immunotherapy. Yet alternative treatments are not researched or even discouraged by oncologists. Why is that?
So I'd have to hear what the specific alternative treatments are, but I guess what I would say is the scientific method shouldn't be a mystery. I'd say, in general, the standard by which oncology, the NCI, wants to progress is you have a treatment you're in favor of. And I don't care what it is, naturopathic treatment, drug, immunotherapy, whatever it is, and you think it works. The way you know that it works for a population is you give some people that treatment and other people don't get that treatment, and you see who does better. Where there is evidence in studies like that the thing that you gave to these people made them better than the people who didn't get it, we pursue it no matter where the origin of that comes from. The problem is there's a lot of claims, I think, made out there, and way more claims than we can go after. So we prioritize going after the ones where there is actually, in a controlled fashion, some scientific evidence supporting the ability of these interventions to work. So it's hard without knowing the exact ones you're talking about, like where the evidence is lacking. But I think one of the things generally I found when I look, because I do look into these things, is there isn't enough evidence to go forward because there haven't been studies in a controlled fashion.
And I just say, like, the immunotherapy is a good example where that paradigm, chemotherapy, radiation therapy, and surgery are the only methods. Well, it's not true anymore, right? Immunotherapy potentially could be a new methodology for treating cancer, right? So the idea of the NIH is not to exclude new ideas anymore. If new promising ideas come up, we want to look at them. But that, I told you earlier, 100,000 applications a year, and we have to pick 8 to 10,000 of them. It means that many good ideas may get left on the table. The changes that we've been instituting at the NIH is to allow more of those good ideas. You can't know in advance if they're going to be good, but good or bad, to get a fair hearing. And so it's again a slow and frustratingly slow, especially for patients who have cancer, process. But it's the only process we know of that actually makes advances in improving health for people in with such dire conditions.
I'd also say there is a risk if there's insufficient evidence to support something. What I hate to see is a situation where there is an effective standard of care therapy available, and that gets set aside in exchange for something that has a lower chance of working. That's something that I do think we should try to avoid.
In those cases, Dr. Latai, I'm curious to get your take. If there's insufficient evidence, should the NCI try to get critical mass of evidence? Like, should you lead the way in getting more data?
I mean, so I'll just try to repeat a concept so that there's, it's hard to address this specifically because I don't know the exact instance you're talking about, but I can tell you that there are many, many, many different, if you want to call them hypotheses out there about how this thing, that or the other thing should work for cancer. Unfortunately, we don't have the resources to definitively test all of them. So we prioritize studying ones where there is the more evidence, the better. If there's a plausible biological mechanism, if there is a therapy or a thing that can be made or created or brought to bear in sort of a reproducible fashion, that will help us prioritize our efforts. But I don't think it's true that we don't. So we have enormous efforts screening natural products tens of thousands, I think probably hundreds of thousands of natural products from around the world. We actually have people going around the world collecting marine plants, mollusks, you name it, all these different things, and extracting natural products and exposing them to cancer cells to see if we see an effect. Okay, this is something that is currently underway, like right now. We continue to do that. And we do that for one reason, to identify things that are outside the normal canon of things that we use that might be novel drugs that we could bring to bear. I would guess most of the, it's hard for me to know because I would guess that most of the chemicals, drugs, supplements that might be at issue here have already been tested at the NCI. And if we haven't pursued them, it's likely because they haven't shown sufficient evidence in controlled experiments to actually kill cancer cells, which is what we need to see.
Thank you, Dr. Atlasai. Another question from the audience. For progressive pediatric cancer and rare diseases, time itself is a critical variable. How does NIH weigh the ethical cost of waiting for perfect data when children are losing from irreversible function in the meantime?
I mean, we take our commitment to studying rare diseases very seriously, because I've talked to so many parents now with patients, with kids who have rare conditions or with sort of advanced cancer. And you're absolutely right, Patrick. Like time is of the essence. But the question is, like, what do you do there, right? Do you make a promise that you don't know is going to be kept? Is that kind of sort of the right thing to do, or do you put them, give them the sort of the care that we know is the best available, and then put them in a setting where their experience can inform the outcomes of others? Sometimes it works out, like you get a major advance, and then all of a sudden you can treat lots of other people with the same thing. But often it doesn't work out, because you're essentially trying to do experimental therapies that we don't know for certain. The ethical obligation we have in science is to not lie to people, right? You have to say, look, here's what's known so far, and here's what's not known, and we're doing the best we can to give you the good advice in a very difficult situation. The unethical thing to do is to promise that something is going to work when you have no idea it's going to work. In fact, I think that's just cruel to do someone in that situation.
Right. In practical terms, it's very unusual that we have something that we really think is going to work that we would not use or would forbid a patient to get. Part of the issue, though, really goes beyond the NIH, and part of this involves interaction with the FDA. And I know the FDA, so you need, in order to start a new clinical trial with a new agent, FDA needs to approve it in something called an IND, initial new drug application. So I think that's initial. And so I will say we're in good shape. We have an FDA that is very willing to change things and is very willing to respond to deficiencies in its system, and is very motivated to make things go faster. So part of this does have to do with that approval process, but I believe that they're very sensitive to that, and they are working to make some of these sort of initial IND approvals more rapid, especially in circumstances where the patient is very high risk, where they don't have a lot of time, and we need to test quickly.
I mean, there's a recent success story. Everyone heard of baby KJ? He was a kid that had a very rare condition, and there was a NIH-funded advance in, I think, the University of Pennsylvania, where they could use essentially like a genetically edited cell therapy, and treat him in a way that would we thought actually address this rare condition. This rare condition that almost always leads to death, and it worked. And it was a collaboration between the university, the professors of the university, the NIH, and the FDA, which approved the capacity to go forward with this. The idea now that you can use cell therapies, essentially N of 1 therapies that are tailored to patients, is going to mean the need for a new regulatory structure, right? Requiring large randomized trials for personalized medicine interventions that have the potential to work, Well, we have to be very careful that people aren't promising things that really have no chance of working, taking advantage of patients in their sort of worst times in their lives, but also at the same time permitting the trying of new ideas out in a setting where there are all these amazing technologies coming out that potentially could transform the management of these conditions.
Okay, we'll take 2 more questions. Here's another question from the audience. Early detection is not the same as prevention. How do you think about the difference between these, and how should the relative allocation of resources be between these two?
They are definitely not the same thing, but they often have to go hand in hand. For instance, you have to, observe a colon polyp. The colonoscopy is an example where the two are pretty unified. That is to say, in many cases, during a colonoscopy, you can observe a precancerous polyp, and during that same colonoscopy, do the prevention, which is removing that polyp. That's actually a rare instance. Most of it are like that. I would say that it's probably not useful to do screening unless you can follow that up with some sort of response to that screening that's usually either preventative or treatment related. So they are very different things, but both are important in terms of like allocating resources to these. I mean, we have to do both. There's no point in having screening without some sort of preventive aspect to it, and it's very hard to know how to direct prevention without some sort of screening aspect.
This is one of the reasons I want to bring health economics back to the NIH. Questions like that are fundamentally have an economic component, right? Because the question is how effective are these? There's a scientific questions that health economists are really good at addressing. Do you do A or B? What mix of A? And Tony's 100% right. You have to do both. And so like guiding, the NIH doesn't make public health decisions like that. We don't get to decide how much money goes to screening versus how much money goes to prevention. But we can do research that help guide people who do make such decisions. And I think that's it's a vitally important one. For a lot of the prevention interventions, eat real food, I think is a pretty good intervention. Exercise regularly is a pretty good intervention for cancer. So, yeah.
Okay, final question here. Cancer mortality has decreased by 30%, but the total mortality and lifespan has stagnated, implying an increase in non-cancer causes of death. Shouldn't the successes of cancer treatments clearly define the effects on non-cancer and total mortality?
Yeah, I mean, I'm a health economist. I'm an economist, so it's always delivering bad news. So the bad news is we're going to die of something. And so if you improve cancer mortality, the flip side is that you're going to die of something else, right? That's not necessarily bad news, but the bad news is that our overall life expectancy has not improved. And so the advances in cancer have not been met with advances in other chronic conditions. And there's still, as Tony said, like tremendous needs in need for advances in knowledge for cancer.
Still the second highest killer, I believe. Overall.
Exactly. So the only approach to this that makes any sense is an all of the above approach. And actually, the idea of like healthy food, healthy lifestyles. The great thing about those kinds of interventions is that they have the potential of impacting so many different conditions and diseases. The goal isn't to like help people live forever. That's not within our capacity. The goal is to have people live longer, healthier lives.
Thank you very much, Dr. Latai and Dr. Bhattacharya. That concludes our panel.